Good morning, everybody. First of all, I would like to thank the organizers and the FSLA and, of course, David for the kind invitation. And it's a huge honor to be here in front of you to share some of the LIFESCREEN results. And as I speak in front of probably the most informed audience about Li-Fraumeni syndrome, I will skip the background and move directly to the genesis of the program that began in 2010, a little bit earlier. Sorry? Oh, okay. And so, yeah, it's better. In 2010, as a medical geneticist, when we had to handle with this kind of familial situation, the first job is to find a cause, find a mutation. Okay, let's believe we found the TP53 mutation, and so now, is it sufficient? No, what is expected for us is what to do with relatives. And we have to face a very big challenge, because due to the broad cancer spectrum of LFS, it has always been challenging to screen and make the right surveillance to the relatives. In 2010, the French surveillance guideline had been written nearly 10 years before by a group of experts already led by Thierry Frébourg and Laurence Bougière. And it consisted in an annual clinical examination by a well-informed physician, and for women above 20, breast screening with ultrasound, and breast MRI was added a few years after. And it seems a bit light compared to the very high risk, and particularly sarcoma risk was expected to be very high, and as this kind of cancer may occur everywhere, anywhere in the body, we didn't control that risk, and it was unsatisfactory, and a multi-organ screening was needed. In the meantime, the whole world, we heard about the Tonto Protocol, and this protocol used total body MRIs. This seems to be an attractive modality to screen. And it was, we wanted to avoid, due to the X-ray radio sensitivity, any X-ray exam, and MRI was the perfect exam to do. And on top of that, it seems to work very well. So, and this was in 2011. So, was whole body MRI the answer to our problem? Maybe it seems really attractive, but that was not that straightforward, because each medal has two faces, and before recommending it, we wanted to balance the pro and the con of this kind of modality. The aim was to detect more early cancer, to have more cured cancer, and humbly save lives. On the con, we know that this kind of modality may lead to more exam, more biopsies, and more distress and a poor quality of life by spending more time in hospitals and radiologists' offices. So we discussed the matter with our favorite statisticians, and they told us, okay, if you want to prove anything, if you want to have solid results, you need a randomization. So that was another point of view, a prevention randomized trial. Are you serious? They were. So we did it. And we designed the LIFESCREEN protocol as a nationwide randomized study made on the comparison of two screening regimens differing only by the use of whole body MRI. And we expected 50 participants in each arm with a minimum follow-up of 3 years. And the main objective was to compare the performance, and the natural main endpoint should have been mortality or survival, but we were a little bit concerned to be underpowered due to the low number of participants and the relatively low expected number of cancer. We expected 12 cancers in 3 years. That's why we chose incidence as a main endpoint. We had a few secondary objectives. The first one was to find early cancer, and the stage of new cancer was interesting, and we wanted to describe anyway the mortality by cancer. And it was a kind of pilot study to see whether it was feasible and acceptable to recommend a yearly surveillance for our patients, and to assess the number of false positives. We also wanted to assess the psychological effect and the quality of life impact of the procedure. And a serum connection was also planned, and virtual banking of the cancer identified during the study for future ancillary biological studies. Our inclusion criteria were very simple. We wanted anybody, any germline TP53 mutation carrier, age between 5 and 71 years. I will come back to this age afterwards. They needed to be affiliated to the social security system, because our ground covered only the whole body MRI and not the other exam, with a feasible follow-up for at least 3 years. People who were under treatment for any cancer could not be included, with the exception of hormonotherapy for a breast cancer. And here are our two arms. The first arm was the standard surveillance arm, based on clinical examination, brain MRI, abdominopelvic ultrasound, radiological surveillance with MRI and ultrasound. And quality of life and psychological effects were assessed through questionnaires. And in some centers, some participants had interviewed with psychologists. And we had blood sampling for complete blood cells and serum banking. And all these exams were supposed to be performed on a single day. And at the end of this day, there was a wrap-up consultation with a physician to debrief the results and to plan the next step of the screening. The second arm, the B arm, was the same as the A arm, plus the use of diffusion whole body MRI. Diffusion whole body MRI gives the advantage to avoid contrast hues that may be an issue in some kind. Here are the details about the whole body MRI. I'm sorry, I'm a mere geneticist and I won't be able to comment the procedure. All I can say is that sedation was not allowed in the trial, and so that's why we limited the inclusion of children for children above 5, considering they would be able to undergo the procedure. Here's the design. Any participant was randomized and allocated to an arm, A arm or B arm. It was possible to refuse the randomization, and they were just monitored and results were collected. The randomization was stratified on age, sex, and personal history of cancer. And at each step, the quality of life and the psychological effects was assessed 1 month after the result. Here are the inclusions. Finally, 29 centers participated. It was mostly adult oncogenetic clinics. I forgot to say that I was involved strictly in adult predisposition. And we had 107 participants accrued in nearly 2 years, in a little bit more than 2 years. And here are the list. Here is a list of the different centers. As France is a bit far from here, it's easier on a map just to show you that we wanted to have a multicentric study to limit the travel, and we didn't want our patients to go too far from their home, and that's why we had that network of centers throughout the country. The population is probably a little bit different because we have a vast majority of adults, 83%, and the mean age was 33.4, and a majority of women in the study, and we have a nearly 50-50 ratio of personal history of cancer. So, what did you find? So we found 31 new primaries, 5 relapse of previous cancer. We had more cancer in the standard surveillance arm, 20 against 11, and we observed an 11% rate of prevalent cancer, so at the beginning of the study, and also 8 interval cancers such as breast cancer missed by the breast screening, leukemia missed by anything as any leukemia, 1 sarcoma, 1 colon, 2 lung cancer, and 1 myeloma. What kind of new primary cancer? As expected, we observed a lot of breast cancer. You have between brackets the age at diagnostic, so 6 breast cancer. We had also brain tumors or central nervous system cancer, sarcoma, and we were a little bit concerned with the sarcoma because the study was designed to identify sarcoma, and we only found very lately in the last month of the protocol the different sarcoma. We had also leukemias, basal cell carcinoma in the same 3 times in the same individual, a bladder cancer, an adrenal carcinoma in an adult, a clear cell renal cancer at 50, pancreas, a myeloma, a colon cancer at 35, and a choriocarcinoma at 30. So if you look at this list of cancer, okay, you have hints towards LFS syndrome, but you have also a broader cancer spectrum than expected. 5 patients had 2 cancers in the course of the trial, and 1 had 3 cancers, so the one with several basal cell carcinoma. That is not unexpected for this kind of tumor. Usually you find several tumors of this type in the same individual. We made biopsies, of course, a total of 48, more in the standard surveillance arm than in the whole body MRI, but this is not significant. And the biopsy was guided by clinical exam. Sometimes there's a whole body MRI, but not that much, only 9. And most of the other biopsy were guided by other radioscan and mainly by breast MRI. That was expected. So, more accurately, on whole body MRI performance, we had a total of 157 exams, and we assessed the performance using false negative and false positive, and we defined false negative as a cancer detected within the 12 months following a negative checkup, and false positive as any spot leading to a complementary test and biopsies are required to dismiss the cancer diagnosis. And here are the results. We had 8 true positives, so signals on the whole body MRI, diagnosis of cancer, 2 false negatives, so cancer missed by the whole body MRI, and we consider different types of false positive. The true false positive, you have a signal on the MRI corresponding to nothing at all, and you have false positive with a real lesion, a benign lesion, without impact. And in that category, we have liver angioma, for example, or breast fibroadenoma. And we had one lesion with impact. It was a benign bone lesion that we wanted to biopsy, just to be sure it was benign. And I would agree with your point. Would this benign lesion once develop into a cancer that we don't know, and it's still monitored. More details about the cancer detected by the whole body MRI. So it picked up 3 lung cancer, 1 choriocarcinoma, but by lung metastasis. 1 ACC that was also viewed by the ultrasound, and 2 breast cancer also viewed by breast MRI, and 1 spinal cord glioma in utero that should have been picked up by the clinical examination because it was painful, but it was not investigated at that time. And so some cancer were missed by the whole body MRI. The myeloma, maybe it could have detected this one, and 1 osteosarcoma also at the jaw. And it missed also 1 breast cancer. I put it between brackets because whole body MRI was not designed to detect breast cancer. And anyway, we had the breast MRI to do. So if you do the math for the sensitivity and the specificity, we had an acceptable 80% sensitivity at 89% specificity, which is not that bad, and it's very close from the breast MRI, for instance. And we had a 10.2% of false positive rates for whole body MRI. So not so bad, and it was one of a goal to try to assess this kind of performance. But the main goal another time is to save lives. So, about the whole body MRI, we had a planned centralized review, and 141 exams were reviewed, and we had 44 discrepancies. 1/3 of the discrepancies because the local radiologist and the reviewer, and the discrepancies went in any way. Sometimes the local radiologist was wrong, sometimes the reviewer was wrong, sometimes both were wrong. So it might be difficult from just a question of point of view. And that's the point. Did we save life? The good point is that the overall survival in both arms, so in red you have, the color code is slightly different, I'm nearly there, is the intensified arm with whole body MRI, and the blue curve is for the standard surveillance. And so at 4 years we have 33% survival rate, which is quite good. Not enough, of course. We would like to have 100%, but there is no difference between the 2 arms, and with a median follow-up of only a little bit more than 3 years. And we updated the data. I can't show you the curve, but it's nearly the same with 1 more year of follow-up. And among the new primary cancer, 8 patients died. 8 patients passed away because of their new primary cancer. And sadly, 3 of our 4 kids died with it. We lost 1 patient with lung cancer, the patient with the adrenal carcinoma. About compliance and acceptability, it was pretty good. We had only a 7% consent withdrawal rate. That's quite good, and I don't have the time to stress on the psychological evaluation briefly. There was no surveillance-associated distress, and there was no, the depression and anxiety remained constant across the study, and there was no difference between the two arms. And in the qualitative interviews, participants insisted on protocol interest, giving them a feeling of control on the predisposition and protection against disease. So expectations are very high. As a conclusion, we can say that we are one of the largest prospective series. The other series are presented in the meeting, so you have the choice. I hope we have proved that randomization is feasible in this kind of research, and multi-center surveillance is also feasible with the same protocol, and it was acceptable by patients because 94% of the patients carry on the screening year after year. And the surveillance is approved and requested by families. We had a few unexpected results about the spectrum: few sarcomas, a lot of lung cancer, and we have, like colleagues, around 10% of prevalent cancer. Diffusion whole body MRI, so there are bad news on this side because in our study it showed no overall survival benefit. It showed difficulties for the interpretation, and we had a few false negatives. But the good point is we had no excess of biopsy, so we did not, this modalities does not annoy a lot the patient, and it's well tolerated, and we had an acceptable false positive rate, and mainly it was the only exam to detect lung cancer, which was very frequent in our series. That's why, despite its limitation, whole body MRI remains really attractive for the screening, and it's a kind of French paradox. Another French paradox, the study is negative, but we keep in mind to use the whole body MRI, and we will probably validate at our next meeting in France and incorporate the whole body MRI in our guidelines. As you saw, we have a few differences with the Toronto results, due maybe to a different population. We had an older population, maybe a French population. Maybe it's due to the randomization or the design. Our A-arm, our standard surveillance, was more than no surveillance or free surveillance. Maybe we have also a shorter follow-up, that's true, and the interval lengths between the screening were also different. So, modalities have to be optimized, probably, and we have to answer a few questions. Which kind of modality? Do we have to add new technology, ctDNA? Do we have to discriminate the patient with methylation pattern, for instance? When do we start? And this is all about penetrance. And what is the exact risk at what age that we say, okay, let's begin at this stage because the risk is increased at that point, and we have to take into account the high interfamily heterogeneity. And I also militate to a customized surveillance. Probably one size does not fit all. Also, we had a poor survival when cancer occurs, unfortunately, and we need to increase better prevention, maybe with drugs or any other modalities, and we need also more efficient treatments. I would like to acknowledge the whole group, French LIFESCREEN group, led by Thierry Frébourg, and I'd like to thank Laurence, who was at the really beginning of the story, all our colleagues in France, La Ligue, the French Link Against Cancer, who funded us, and of course the patients and their family. I thank you for your attention, and I'm ready to answer your questions.
Okay, we'll take maybe one or two questions. Judy.
Sorry. That was really beautiful, and thank you for sharing the data with us. My only question to you really is about GI cancer screening, which is not part of the protocol, and whether you recommend that in guidelines in France. And I guess my second question is, do you think you'll be refunded?
Yes, we didn't screen GI cancer in TP53 carriers. That was true in 2010 when we designed the screening, and it's also true today. We just use the family history. If we have colon cancer in the family, then we use colonoscopy, so it has to be discussed.
We'll have time for one more. Sorry, David.
Fantastic. It's lovely to see. You said that it's feasible to do randomization. My question is it now feasible with the results out to do randomization?
Yeah, sure. It's an old story. Again, it began in 2010. At that point, we didn't have the result. If we had to do it again today, would we do exactly the same? Probably no. But anyway, I'm sure if we have to ask the same question at the statisticians, they will always say the same. Okay, don't just use randomization. How? It's a question of discussion.
Great.
Okay.
Great. Thank you very much.